Thorax Chapter 17, the shoulder and the shoulder girdle. So we know that our shoulder complex is made up of our shoulder girdle and our glenohumeral joint. And these are all synovial joints. So we have our glenohumeral joint, and then our shoulder girdle has our acromioclavicular joint and our sternoclavicular joint. And we know each of these articulations are between the bones that they're named for. So our glenohumeral joint is going to be the articulation between the glenoid fossa and the humerus. Our acromioclavicular is going to be the articulation between our acromion process and the clavicle. And our sternoclavicular is going to be our articulation between the sternum and the clavicle. If we look at these articulations functionally, we have the scapulothoracic joint and the shoulder joint. So the scapulothoracic articulation is the scapula sitting on the thoracic spine. We have our motions of the scapula include elevation, depression, protraction, and retraction. We know that we need upward and downward rotation for appropriate flexion and extension movements as as in order there. So upward rotation coinciding with shoulder flexion, downward rotation coinciding with shoulder extension. And then we also see internal and external rotation of the scapula in slight degrees and anterior tilting of the scapula. Primarily when we're looking at the scapulothoracic joint, we're looking at improving scapular stability because we need scapular stability in order to superimpose upper extremity movement. Scapular stability is going to be dependent on a postural relationship, so we need adequate thoracic extension in order to get full overhead motion, and if we don't have appropriate postural alignment, then the scapula can't sit in appropriate alignment and therefore doesn't rotate with the humerus the way that it needs to. We also need to look at the space, the subacromial space between the acromion process and the humeral head, because we have a lot of tendons that pass through there, and that is our most common space risk for impingement. And so our scapular positioning affects our subacromial space. If we have kyphotic posture, if we have rounded shoulders, all of those things are going to contribute to decreasing that subacromial space and increasing the risk for impingement. We should be pretty well familiar with our scapulohumeral rhythm by now, but that's our 2-to-1 ratio where we have 2 degrees of glenohumeral movement for every 1 degree of scapular movement, and both are required for full overhead motion. Scapular dyskinesia, so that's going to be dysfunction of the scapula in the way that it moves, and that can be caused by a couple of things. We talked about how posture influences scapular positioning, and faulty posture can also contribute to scapular dyskinesia, because if we have the thoracic spine sitting in an improper alignment, then we're going to have muscles pulled in an improper direction. And when they're not pulling in the right direction, or they don't have the adequate excursion length, then they're not going to function properly and cause dyskinesia. So we need full thoracic extension to achieve full end range overhead reach. We can also see faults within the scapulohumeral rhythm where we're not getting adequate rotation of the scapula on the thoracic spine to contribute to that full overhead motion, and so we have to train the muscles appropriately to contribute to overhead reach. Other causes can include neurologic impairments to the muscles, congenital issues with development of the scapular girdle's growth, but there's many factors that can contribute, but our primary ones that we want to look at are going to be faulty posture and that scapulohumeral rhythm. Clavicular elevation and rotation happen with humeral motion, and so if we're seeing restrictions at the end range of flexion trying to get that overhead reach, then we may want to look at how the clavicle is moving and whether or not mobilizations to the clavicle are required to improve that overhead reach. Because of the positioning of the greater tubercle and the acromion process, we need to see external rotation of the humerus occur with elevation so that we don't cause impingement of that subacromial space. And it is important to remember that the capsular pattern for the shoulder is loss of external rotation greater than in first, before loss of abduction, and then loss of internal rotation. Referred pain and nerve injury with the shoulder. So referred pain is going to be pain that is coming from a different area that we are perceiving in the shoulder. Nerve injury is going to be pain that is caused by injury to the nerves surrounding the shoulder. So common sources of referred pain in the shoulder region are going to include the cervical spine. We can often have cervical spine dysfunction that refers as shoulder pain, and actually vice versa. And referred pain from related tissues, or I think that really should say unrelated tissues, but these are going to be more of our systemic referred pains. So right shoulder blade pain is going to be associated with gallbladder. Left upper extremity pain is going to be associated with cardiac issues, and left shoulder pain is going to be associated with spleen issues, and that's what we call Kerr's sign. So these are pains that aren't improving with interventions the way that we would expect them to. Do we need to look for different possible causes and refer them back to their doctor to have these things investigated? I would say that for the immediate moment, these referred pain patterns aren't super important, but they do have the potential to come up for your licensure exam, and so I would at least familiarize yourself with understanding the concept of referred pain, so that way when you're studying for your licensure exam, these aren't completely new concepts. When we look at nerve disorders in the shoulder girdle region, we can see brachial plexus injuries in the thoracic outlet. So if you remember the space between the clavicle and the first rib, we have our thoracic outlet, and the brachial plexus runs through there, and compression of that space can cause brachial plexus injuries. The suprascapular nerve can be damaged at the suprascapular notch, and we can also see radial nerve damage or compression in the axilla, especially when we look at patients who are utilizing crutches. This section is going to take us through different shoulder diagnoses and considerations that we need to keep in mind when developing a treatment plan for our patient. We're going to go through specific shoulder interventions in lab. We'll start off with joint hypomobility, so that's going to be reduced movement or motion. And looking at non-operative management of joint hypomobility, we're going to focus on the glenohumeral joint because that's what we will most commonly have referred to us for therapeutic treatment. It can be related to various pathologies and different symptoms. Most common causes are going to be things like rheumatoid arthritis and osteoarthritis. We can have traumatic arthritis, which is an onset of arthritic changes as a result of trauma to the joint, post-immobilization arthritis or stiff shoulders, and idiopathic frozen shoulder. And remember, idiopathic means without a known cause. Looking at clinical signs and symptoms, so how these things would present, we're looking at glenohumeral joint arthritis. That's going to present like a typical arthritis where we see increased pain with compression of the joint, so any kind of weight bearing through the upper extremities will increase pain, but they see a reduction in symptoms with distraction at the joint, decreased stability due to poor muscle firing, those types of signs and symptoms, pain with motion, pain that increases as the day goes on, decreases as they are able to rest. Idiopathic frozen shoulder, we're going to look at the 4 stages of that and how those present. So stage 1 is what happens in the first 3 months, so less than 3 months of onset. This presents with a gradual onset of pain, a loss of external rotation with maintenance of strength. So remember from our capsular pattern that external rotation is the first movement lost and the one that we lose the most motion of. And so it lines up that external rotation would be our first motion lost. In stage 2, so from months 3 to 9, the patient will present with persistent pain with motion limited in all directions. Stage 3 is going to be months 9 to 15. They will experience pain only with movement and limited glenohumeral movement, so they're going to be pretty well stuck. Stage 2 is what we refer to as the freezing stage. Stage 3 is the frozen stage. Stage 4 is going to be 15 to 24 months. They will have minimal pain with significant capsular restrictions. This is going to be what we call the thawing stage. Common impairments with glenohumeral joint hypomobility are going to include loss of movement following the capsular pattern. So remember, external rotation, then abduction, then internal rotation. They'll also experience pain with movement and decreased mobility and strength. Common activity limitations and participation restrictions are going to be the inability to reach overhead or behind their back, and difficulty with lifting objects. So when we're thinking about our treatment plan in treating patients with glenohumeral joint hypomobility, we want to think about interventions that are going to help address these impairments and help them reach the goals of restoring the activity limitations and participation restrictions. During the protection phase, we are going to educate the patient, provide them on ways to modify activities to decrease pain, limit further injury, help support and stabilize for positioning, ways that they can help prevent the injury from becoming any worse. We're going to help them control pain, edema, and muscle guarding. The use of grade 1 and 2 joint mobilizations may be appropriate for this population. Remember, PTAs in the state of Oklahoma are permitted to perform grade 1 and 2 joint mobilizations. They typically are better targeted for pain control than improving movement at grades 1 and 2. Grades 3 and 4 tend to be better for improving mobility, but 1 and 2 for pain management. We want to maintain soft tissue and joint integrity and mobility, so we're going to perform range of motion. We will do stretching activities as appropriate as long as it doesn't injure the tissues or increase pain for the patient, and maintain integrity and function of the associated region. So we want to make sure that we're promoting scapular motion, keeping the elbow and wrist moving, sometimes even looking towards the cervical spine and ensuring that there's appropriate motion being maintained at all of the associated regions. During the controlled motion phase, we're going to continue to provide patient education and continue to control pain, edema, and joint effusion with modalities and interventions as appropriate. We'll progressively increase joint and soft tissue mobility, so this might be where we progress from passive range of motion to stretching in some of those more vulnerable tissues. We'll inhibit muscle spasm and correct faulty mechanisms, so we're going to try to promote proper muscle firing through all motions that they currently have and as we train for new motions. We'll improve joint tracking, so ensuring that we get appropriate scapulohumeral rhythm and that there's no faulty tracking in the overhead motions that we're trying to achieve, and improve muscle performance looking at strength, endurance, and power. For return to function phase, we'll progressively increase flexibility and strength and prepare them for functional demands, going pretty well in line with the name of the phase. In patients that are unable to improve range of motion, flexibility, and overall movement with therapeutic interventions, they may undergo post-manipulation under anesthesia, so they will put a patient under and move the shoulder while they are anesthetized, so that way they can't fight, there can't be any muscle guarding, any of those things, and try to break up some of the adhesions in the capsule that are restricting motion. On the flip side of hypomobility, we have hypermobility or instability. When we are looking at patients with glenohumeral joint hypermobility, we want to take special considerations to avoid the combined positions or motions or the mechanism of injury that caused the hypermobility or the dislocation or subluxation, especially during the early phases of rehab. We want to really protect the joint. Hypomobility may also be coming from the acromioclavicular and sternoclavicular joints, and these can be caused by overuse syndromes, subluxations or dislocations, or even hypomobility, so restriction of any of the soft tissue structures surrounding each of those joints. These patients are going to present with an inability to sustain repeated forceful movements of the arm and an inability to reach overhead or perform repetitive overhead motions. I don't really like the layout of this slide, so we're going to talk about the bottom first to stick on hypomobility. So if we're seeing patients with non-operative management of AC or SC joint hypomobility, we'll use manual techniques like those grade 1 and 2 mobilizations of each of those joints, manual stretching, and then also teaching the patient self-stretches. On the flip side, if we are treating a hypermobility at the AC or SC joint, again, we want to avoid the combined position or motions of the mechanism of injury that cause the dislocation, subluxation, or strain at the joint to protect those healing tissues, especially during the early phases of rehab. If the shoulder can't be managed non-operatively, then they will decide to do surgery. Common indications for surgery are going to include acute or non-union fractures of the proximal humerus or advanced destruction of the GH joint, so those arthritic changes. Common surgical procedures be a glenohumeral arthroplasty or shoulder arthroplasty, and we know we have a reverse and a regular total shoulder arthroplasty. and an arthrodesis. And the goals of each of these surgical interventions are going to be to relieve pain, restore or improve mobility and stability, or restore or improve strength and function. Patients who are candidates for an arthroplasty are going to present with persistent pain and loss of function, and they can opt for a total shoulder arthroplasty, reverse total shoulder arthroplasty, or a hemiarthroplasty, which is only part of the joint. Looking at post-operative management, special considerations, we need to think about the rotator cuff integrity. It is very important to remember that our goals and expected outcomes for rehabbing a total shoulder patient are going to depend on the integrity of the rotator cuff. If there is not an intact rotator cuff or there has been damage to the rotator cuff, then they're going to need a slower rate of progression and probably lower level goals. We also need to know what their intraoperative range of motion was, because that's going to indicate what their potential range of motion is going to be outside of surgery. Typically, they will be placed in a sling or an abductor sling, and so we need to make sure that we provide appropriate education on making sure that the shoulder is appropriately supported with that sling and with use of pillows in other positions and anytime they're not wearing the sling. During the maximum protection phase, that patient education is going to be a huge part of what we do as therapists, and we're also going to help them with pain management. We need to ensure that we are maintaining mobility of the adjacent joints, so looking at movement of the spine, the scapula, the elbow, the wrist, all of those important things. And range of motion as permitted by the protocol. We need to make sure that we're following in line with the protocol and strongly educating our patients on avoiding reaching behind the back. In the moderate protection phase, we will work to increase the range of motion and initiate active shoulder movement and stability. And then as we help promote them returning to function, we will do end range self-stretching, progressive resistive exercises in diagonal patterns, so working those PNFs that we will have a printout of but also elaborate more on in neuro. And then closed chain shoulder exercises, trying to get some weight bearing through the joint compression for the neural innovation or neural adaptations, and promoting functional movements. Painful shoulder syndromes, looking at rotator cuff disorders and tendinopathies with non-operative management. So rotator cuff disorders, we can see intrinsic impingement, which is rotator cuff disease that's impingement within the tendon and breakdown coming from within the muscle itself, or extrinsic impingement, which is mechanical compression of the tissues typically occurring in that subacromial space. Tendinitis and bursitis, so our most common is going to be our bicipital tendinitis. Remember, the long head of our biceps runs through the bicipital groove in the humerus, and inflammation there it's got a tight space to pass through, and so that can cause significant irritation. Bursitis can happen at the subdeltoid or the subacromial bursa. We can also see impairment of other musculotendinous tissues, but these are going to be our most common that we will encounter in the clinic. These patients will present with an impaired posture and muscle imbalances. Most commonly, we will see tightness through the pecs and weakness through the scapular retractors. They will have decreased thoracic range of motion. Again, remember, we need full thoracic extension for overhead motion. And again, this is going to be associated with more of that kyphotic posture with the decreased thoracic extension, again, tying to the rounded shoulders where we see the tight pecs and the weak scapular retractors, so our middle trap and our rhomboids. There's rotator cuff overuse and fatigue, and typically a compensation pattern with scapular elevation that happens as a result of that with overhead motion. Muscle weakness secondary to neuropathy, if we see impingement or compression of the nerves as a result of the inflammation associated with these disorders, that can cause further weakening of the muscles surrounding the joint. And hypomobility of the posterior glenohumeral joint capsule. So how do we treat it? During our protection phase, we're going to work to control inflammation and promote healing. We want to provide patient education on appropriate ranges of motion activities to avoid appropriate pain modulation activities such as ice and rest. We want to maintain integrity and mobility of the soft tissues and try to protect them as best that we can while keeping them as mobile as best we can. Control pain and maintain joint integrity, again utilizing grade 1 and 2 joint mobs as appropriate, and develop support in the related regions. So, appropriate postural alignment is a necessary first priority to promoting proper scapulohumeral rhythm. So, we may need to focus on correcting postural alignment and then building scapular stability before we incorporate the overhead motions or whatever exacerbating motion is causing the painful shoulder syndrome. During the controlled motion phase, we'll continue to provide patient education about appropriate activities to participate in, modifications that are needed, appropriate support and pain management, all of those things. We'll develop strong and mobile tissues with resistance training as appropriate and stretching, again, as appropriate. Modified joint tracking and mobility with neuromuscular training and proprioceptive training. Develop balance in length and strength of the shoulder girdle muscles. So again, looking at, do we have tightness on one side that's producing weakness on the other side? Where do we need to stretch and where do we need to strengthen? You guys will go over this in posture again, but typically for most joints, when we have a tight muscle on one side, we also have a weak muscle on the other side, and our tight muscle is weak in its range that it hasn't been used in yet. And so we need to strengthen on both sides of the joint, but we can't neglect strengthening the opposite side that we stretch. So if I stretch the pecs, I also need to strengthen the rhomboids and middle trap. Develop muscular stabilization and endurance, again, so that we can superimpose those upper extremity movements and progress shoulder function. Our return to function phase is going to promote muscular endurance and develop quick motor responses to impose stresses. So this might be where we start to implement some of the plyometric exercises of the shoulder, and again, progress functional trainings to restore the patient to their prior level of function. So moving on to painful shoulder syndromes that they do perform surgery on. The first that we'll talk about is going to be a subacromial decompression, and postoperative management for that is just going to follow the phase guidelines that we just talked about for rotator cuff disorders and tendinitis. For a rotator cuff repair, postoperatively, we're going to have them immobilized per the protocol. Most of the time, they will only be allowed out of the sling for therapy purposes. And so we want to make sure that we educate the patient on that appropriately and encourage them to don it all of the time that they are supposed to. During the maximum protection phase, we're going to focus on controlling pain and inflammation, so we'll utilize ice, we'll keep them moving as much as we're allowed to for the joint weeping. For inflammation, we'll teach them about positioning and how to prop themselves up to, again, reduce inflammation. We're going to prevent loss of mobility in the adjacent regions, looking at the spine, the scapula, the elbow, the wrist. We want to prevent shoulder stiffness staying within our protocol guidelines, so we will provide passive range of motion in appropriate ranges within the appropriate timeline as indicated by our protocol. We want to prevent or correct postural deviations. Again, wearing a sling typically pulls you into that kyphotic posture, and so we need to work on the thoracic extensors and the scapular retractors. We want to build scapular control and stability, prevent glenohumeral muscular atrophy as needed. So setting exercises at the shoulder should be avoided until the patient is at least 3 weeks post-op, but as soon as they are cleared per their protocol, we want to initiate muscle setting exercises for the rotator cuff muscles so that we prevent atrophy from developing. We don't want excessive tension to develop in the tendon, especially in a tendon that's been repaired, but we do want to prevent atrophy, especially in all of the surrounding musculature. So our 6-way shoulder isometrics tend to be a good one for that. During the moderate protection phase, we're going to work to restore pain-free passive range of motion while the patient initiates active range of motion of the shoulder, and it works on dynamic stability. During the return to function phase, we want to continue to increase active range of motion to restore full range of motion as much as possible, implement PREs and diagonal patterns, utilize closed chain exercises for weight-bearing inputs, and implement functional movements to return to function. Shoulder instabilities, so these are going to be related to our hypermobile shoulders, non-operative management. So looking at conditions that we might treat with non-operative management are going to be atraumatic hypermobility, so nothing has happened to cause damage to structures, they just have hypermobility, and that can be unidirectional or multidirectional. We can also see traumatic hypermobility where some trauma caused it, and that's typically an anterior or posterior shoulder dislocation. And we can also see recurrent dislocations. When treating a patient who's had a closed reduction of an anterior dislocation, so they dislocated anteriorly and somebody just popped it back in, we're going to, during the maximum protection phase, avoid extension beyond neutral because that is contraindicated. We want to protect the healing tissue. So remember, the anterior joint capsule would be the healing tissue there, and promote tissue health. During the controlled motion phase, we will provide protection, increase their shoulder mobility, and increase stability and strength of the rotator cuff and scapular muscles to decrease the requirements of the static stability structures within the glenohumeral joint. During the return to function phase, we're going to restore functional control and return to full activity. This is going to follow the same progression for a posterior dislocation, except we want to avoid humeral flexion with adduction and internal rotation during the acute phase of healing for a posterior dislocation. And a posterior glide is contraindicated, again, because the capsular laxity has already been increased posteriorly. We don't need to increase it anymore. We can also see shoulder instability that has to be repaired operatively, and that's going to include a handful of different procedures. So we can see a Bankart repair, a Latriette repair, a capsular raphe, which you remember the demonstration in class is what you guys saw pretty recently, an electrothermally assisted capsular raphe, a posterior capsular raphe, or a repair of a SLAP lesion. Postoperatively, we are going to treat these patients with care because we don't want to have any more dislocations or any more instability, and so we need the repairs to take effect. So we want to protect the repaired regions. There's some general considerations listed in Table 17.5 in your textbook on page 610. I would take a look through those just to kind of understand how you would factor that into your clinical decision making. And the length of immobilization for each procedure is going to vary, and that's also going to be a factor and one of those considerations that's discussed in that table. But basically the general rule is that we want to promote stability with active muscle firing in safe ranges first and ensuring that they are stable before we continue to progress. Outcomes that we are looking for is we don't want any recurrence of instability, and we want to restore shoulder range of motion to the best of the patient's stable ability. Now, I have a handout of all of these diagnoses and management and considerations, contraindications that I've put together for you guys to help have it in a consolidated place for you to understand and study and reference as we go through our lab activities for this. Before class, I want you guys to review the exercises and the stretches in the textbook in the remainder of this chapter. Your version of the PowerPoint has the remainder of the slides over those, but since we're going to cover them in class, I just didn't want to cover them in the video. But we're going to perform these on each other in class. You also need to prepare lab-appropriate clothing for shoulder exercises, but I think you guys are pretty good at that. We will be going over your case from your textbook, so ensure that you have access to your F.A. Davis resources as well.